some of you visit here in New York in the future. It's called the Morgan Stanley Children's Hospital of New York. Uh, it has that name because Morgan Stanley was a major contributor to the hospital. And up here on the next to the top floor is the neonatal ICU, and which distinguishes us is we have a separate cardiac NICU. I think we're the only cardiac NICU in the world, and it's entirely run by neonatologists. So we take care of babies preoperatively and then immediately postoperatively until they recover. And I've hired faculty who are dually trained in cardiac intensive care and neonatology. Now, we're known for our excellent care and our use of non invasive ventilation around the world, but in the US, we're known for having the best looking faculty and nurses. I see you say to yourself, how good looking could your faculty and nurses be? Here they are. It may look like someone familiar to you, but this is an actual picture taken from our main NICU. Now, when a baby has a suspicion of sepsis raised, there are three options for us as neonatologists. If we have a low suspicion, we can have the baby stay with the mom and just check in periodically. Or if the suspicion is a little higher, we can come back and examine the baby on some sort of regular basis. And this is a picture of one of our famous alumni from Columbia, Virginia Apgar. When we're really concerned, obviously, we take a blood culture, put it in an IV, and we give parental antibiotics. Now, when I was a fellow in neonatology way back in the 1970s, when someone said, Rich, you have a baby with sepsis to work up, for me, that was sort of an automatic response or no brainer. We took a blood culture, we started antibiotics, usually back then, penicillin and kanamycin, and treated most babies for about 5 days, whether cultures were positive or cultures were negative. Now, we realize that sometimes aminoglycoside antibiotics can have toxicities, certainly ototoxicity and nephrotoxicity. Back in the 70s, though, we didn't realize that some antibiotics were associated with an increased infant mortality, and there are several studies relating use of third generation cephalosporins to increase infant mortality. And there's this whole question of dysbiosis, a change in the flora of the baby from sort of protective flora to more virulent flora, and that has been associated with a higher risk for bronchopulmonary dysplasia, necrotizing enterocolitis, and even late onset sepsis. What we should have realized is that the indiscriminate use of antibiotics separates mothers and babies, delays breastfeeding, and certainly bonding, leads to a risk of unnecessary procedures and testing. And I put on the risk of IV infiltration on the slide. It's not a trivial risk. We probably have one or two babies a month that has a significant IV infiltrate. And clearly, it prolongs the baby's hospitalization and increased expenses. And these are data from a large survey study. The database is over 2 million, done by Malloy, published in 2014. I remember at that time, the recommendation from national committees was to admit and treat every baby born to a mother with chorioamnionitis. And Malloy estimated the cost to prevent one death by admitting and treating every infant exposed to chorioamnionitis for at least 48 hours would be over $10 million. And remember, this paper was written in 2014. It's just US information. You can imagine the costs worldwide. Let me start with some numbers, some of which I'm sure you know. This is looking at sepsis incidence per thousand live births and sepsis mortality. So in our term babies beyond 37 weeks gestation, the incidence is about 0.5 per thousand live births. That's a generalized incidence. Obviously, if a baby is born to a mother who has chorioamnionitis, the incidence is a lot higher, probably closer to 4 per thousand live births. And the mortality rate in our term babies is low, and in most studies, about 1 or 1.5%. With increasing degrees of prematurity, the rate of sepsis goes up. 25 to 28 weeks gestation is 6 per thousand, and at 22 to 24 weeks gestation, it is 32 per thousand. Sepsis mortality in those gestational age groups is 30% in this gestational age group and 50% in our most immature babies. Now, these are numbers which tell you how significant a problem is and why it's difficult to identify the baby with sepsis. First of all, it's an uncommon disease with an incidence of half to 1 per 1,000 live births. In fact, in our late preterm and term population, the incidence of sepsis may be as low as 1 in 25,000. That's why I say it's like finding a needle in a haystack. Sepsis workups, as you might imagine, are far more common than babies with proven sepsis. And we do most of our sepsis workup for clinical symptoms and signs in the baby, but most of these babies have non-infectious conditions. Now, in preterm babies, the issue of sepsis is much more important. For example, in our very low birth weight population, the incidence of sepsis is about 9 to 11 per 1,000 live births, and that's to be contrasted with our term population, where it's 0.5 to 1 per 1,000 live births. 75% of deaths from sepsis occur in our VLBW population, who weighs less than 1,500 grams. And we know from several studies that about 90% of very low birth weight infants receive broad spectrum antibiotics. And in the ELBW group, about a third of those babies receive antibiotics for more than 5 days. And prolonged antibiotic therapy has been associated with, in several studies, with increased risk of death, BPD, late onset sepsis, and necrotizing enterocolitis. So the question I want all of us to think about is, how do we identify the infant with clinical signs or risk factors who's actually affected? That's like finding a needle, as I said, in a haystack. Or the corollary is, can we safely decrease antibiotic exposure in newborn infants who are at lower risk for sepsis? And these are the opportunities to decrease antibiotic exposure. One are healthy appearing late preterm and term babies, or at least 35 weeks gestation, with any risk factor for infection, and that includes intraamniotic infection, or what's commonly called chorioamnionitis. The second large category of babies who probably don't need much in the way of antibiotics are preterm babies with no risk factors for infection, born by elective cesarean section for maternal indications, with either artificial rupture membranes or rupture membranes at delivery. And I'm going to focus this lecture on our late preterm and term babies and how we might decrease the use of antibiotics if they appear well at birth. And the two methods or two strategies which have been used are the sepsis calculator, or any kind of similar scoring system with observations. And then there's just serial laboratory testing without serial observations without any laboratory testing. And some people have talked about using serial observations with screening labs. I'm not a fan of that approach because most screening labs have a very poor positive predictive accuracy. Now, using a calculator is different than doing serial observations. Serial observations are waiting for symptoms to appear in the baby and then deciding whether they're likely to be due to sepsis or not. Where the sepsis calculator takes into account risk factors plus the baby's clinical signs. So slightly different approaches. Now, whenever we talk about any topic in neonatology, we like to see evidence. Unfortunately, that's not always true. It's especially true about dealing with babies with sepsis. This is a very famous quote, not done by a physician. It's done by a famous astrophysicist from Yale named Carl Sagan. And his quote was, "Absence of evidence is not evidence of absence," which means that just because you can demonstrate it in an evidence-based approach, it doesn't mean it's not true. And I'm not as eloquent as Dr. Sagan, and I would say my quote is, "Evidence is not all it's cracked up to be." Now, babies can get infected in one of 4 different ways. 2 of them are very uncommon, like retrograde infection from the mother's abdominal cavity or infection introduced at the time of amniocentesis, both very rare events. More common sources of infection are hematogenous infection through the placenta. Those are the chronic congenital infections, often called the torch infections, which can infect the fetus. But most early on sepsis involves the spread of microorganisms from the vagina up into the uterus, causing a chorioamnionitis. The new term is intraamniotic infection, leading to sepsis in the newborn infant. So, how significant is chorioamnionitis or intraamniotic infection as a risk factor? Well, it depends on gestational age. If you are a late preterm or term baby and the mother has clinical chorioamnionitis, the risk of sepsis is actually quite low, anywhere from 0.4% to 1.24%. And that's why many people are not routinely treating well appearing babies born at that gestational age, even with a history of maternal chorioamnionitis. It's much higher in our population of babies who are born at earlier gestational ages. So at 23 weeks, and at 23 weeks is the lower limit of viability at Columbia, the incidence of clinical chorioamnionitis in mothers is about 26%, and early onset sepsis is seen in about 20% of those cases. At 28 weeks gestation, the incidence of clinical chorioamnionitis is only 14%, and only about 1% of those babies will have early onset sepsis. So the more immature the gestational age, the greater the risk of amnionitis, the greater the risk of sepsis. Now, it's important to remember that intraamniotic infection can be overt or subtle. So in our late preterm or term population, the obstetricians generally rely upon signs of infection, such as a maternal fever, or signs of abdominal tenderness, or foul or cloudy smelling amniotic fluid, or fetal or maternal tachycardia. But in our more immature population, the effects of infection can be very subtle. This is a figure from a famous paper by Bob Goldenberg from Columbia. And it looks at the subtle approach to infection of the fetus. So organisms spread up into the birth canal, into the amniotic cavity. The fetus remains within the amniotic cavity. There's no ruptured membranes, no preterm labor, but a choriodeciduitis is developed. And eventually that choriodeciduitis can lead to ruptured membranes or to preterm labor. And in fact, in 2017, the American College of Obstetrics and Gynecology recommended abandoning the term chorioamnionitis, which you've used for years, and replacing it with a new term, intraamniotic infection, to signify infection of the fetus, the amniotic fluid, fetal membranes, decidua, or placenta. The definition of chorio, the old term, or intraamniotic infection is important because it determines subsequent management of the newborn baby. And over the years, there have been a lot of national and international guidelines. In the US, we have the CDC and the Committee of Fetus and Newborn, but there's also the NICE guidelines in Europe out of the UK. And they sort of all said the same thing. They said in a well-appearing baby, if the mother has chorioamnionitis, again, that's the old term, then you ought to get a blood culture at birth, get a white blood count and differential count with a CRP at about 12 hours of life, and in every case, start broad spectrum antibiotics. Those are the old recommendations. Many of them were mine because I was a consultant to the CDC and I wrote the report from the Committee of Fetus and Newborn. And for that, I'm sorry, because those recommendations were not correct. And they had consequences, and these were some of the consequences, as you might imagine. Many more babies were worked up who were well appearing for sepsis, prolonged antibiotic therapy based solely on laboratory values, high CRP or high white count, increased length of stay, which we've already talked about, and unnecessary invasive procedures with a lot of lumbar punctures, especially with the NICE guidelines. So the question is, can we diagnose intraamniotic infections with better precision? And there are lots of ways of diagnosing intraamniotic infection. We can look at the placenta, do a histologic exam. That information is usually not there for several days. Or we can look for elevated cytokines and amniotic fluid, more of a research tool. Sometimes there's a sample of amniotic fluid, and we look for a positive culture, a positive PCR from amniotic fluid. Most of the time, we rely upon clinical signs in the mother: maternal fever, tachycardia, leukocytosis, high CRP, vaginal discharge, or uterine tenderness. The diagnostic criteria established really in the 1990s by Ron Gibbs look a lot like this. They define chorio as unexplained maternal fever greater or equal to 100.4 degrees Fahrenheit or 38 degrees centigrade, plus at least two other clinical findings: maternal tachycardia, fetal tachycardia, elevated maternal white count, uterine tenderness, or foul smelling amniotic fluid. But these criteria are too general and led to a lot of diagnoses of infection when infection was very unlikely. In 2015, I led a workshop at the NICH, at the NICHD, in which we proposed new terminology to replace the term chorioamnionitis, and we called it triple I, which represented intrauterine inflammation or infection. And the whole purpose of that was to distinguish women with non-infectious cause of fever from those with true chorioamnionitis. And we identified three categories. We called it triple I: isolated fever, not due to infection; then a suspected triple I, where there's a high index of suspicion; and then definite triple I. In 2017, ACOG finally followed our lead and came up with new definitions for intra-amniotic infection. First of all, there was a category of isolated maternal fever, a temperature of 38 to 39 degrees centigrade with nothing else. And that's what you might see, for example, with a mother who got an epidural. Then there's suspected intra-amniotic infection, which is a maternal fever greater than 39, or 38 to 39 with one additional clinical risk factor, such as maternal leukocytosis, purulent cervical drainage, or fetal tachycardia. And finally, there's a confirmed category based on tests on amniotic fluid consistent with infection or evidence of placental infection or inflammation. And here were the recommendations. When intra-amniotic infection is suspected or confirmed, that mother ought to receive intrapartum antibiotics. Antibiotics should be considered in women with isolated maternal fever unless a source other than intra-amniotic infections is identified and documented. And I don't like this because it gives obstetricians a sort of a way out from not giving antibiotics and not making that diagnosis. But much of maternal fever is not due to intra-amniotic infection. So fever is still being used as the sole criteria for intra-amniotic infection by obstetricians. The source of fever may be extrauterine, say the mother has a viral illness or has a urinary tract infection, or environmental, perhaps she received an epidural. And the diagnosis is a guess on the part of our obstetrical providers before laboratory data are available, therefore it lacks precision. Let me present you a recent case from Colombia. This is baby Kim, delivered at 37 and 2/7 weeks gestation, following ruptured membranes for 26 hours. The mother was culture positive for group B streptococcus and received intrapartum antibiotics, ampicillin gentamicin, 2.5 hours prior to delivery for a temperature of 38. So she had a significant temperature and was colonized with group B streptococcus, and there was premature rupture of membranes. The baby was suctioned and dried by the nurse and placed on CPAP as we do at Columbia. APGAR scores are pretty good. And in fact, all the respiratory distress quickly resolved and CPAP was discontinued. And I'm going to prove to you this is a real case. And here is baby Kim wearing glasses and looking very alert. So I can't see a show of hands, but my question for all of you to think about is, how would you manage this infant? Again, prolonged rupture membranes, maternal fever, maternal colonization of group B streptococcus, but a healthy appearing baby. So choices are supportive care and no antibiotics, testing, or cultures. Blood culture, second choice is blood culture and then give antibiotics to the baby. And the third is to do some screening tests in a blood culture. So of the three choices, I think number three is the poorest one. I don't like the value of screening laboratory studies or blood culture. My choice is number one. I'll try to give you my rationale in a few moments. But for those of you who are still doing blood culture and broad spectrum antibiotics, I can't fault you because those were the old recommendations from national committees. In general, how I approach these babies, I ask myself, is the baby symptomatic or well appearing? And are there risk factors or no risk factors, and what are they? So if a baby is born and they're critically ill and symptomatic, I call that a no-brainer. You're going to treat any severely ill baby and give that baby antibiotics. If the baby's well appearing, but there's risk factors, you have a lot of choices. You can decide to observe it, and I think in a lot of babies, that's probably a good option. Or you might decide to do diagnostic testing to help you with your decision. Although, again, I'm not sure diagnostic testing provides an answer. Or if the mother had choreo and it's a preterm birth, you might decide to treat that baby. But there's a third category of babies I want you to think about. Those are babies who do not have risk factors and not critically ill. For example, this could be a baby delivered by elective cesarean section or a baby with TTN. What do? I observe those babies. If the symptoms go away, I say it's a well appearing baby. If the symptoms persist, then you're stuck. Some of you might use diagnostic testing. If it's abnormal, you might treat the baby. If it's normal, you might decide not to treat the baby. But persistent symptoms in babies often get treated with antibiotics. So this is out of most textbooks. These are the risk factors for early onset sepsis. And you can see right at the top of the list is prolonged rupture membranes for more than 18 hours, where the incidence of proven sepsis is about 1%. That's 1 in 100, quite high. Combinations of risk factors shown at the bottom of this list, like prolonged rupture membranes in preterm birth or prolonged rupture membranes in the low outbreath score, have incidences of sepsis of 3 to 6%. But I want you to look over here where it says GBS positive next to the arrow and chorioamnionitis, with the incidence of proven sepsis of 20%. And that is why the old recommendation said if a mother is colonized with group B streptococcus and has choreo, go ahead and treat that baby with empiric antibiotics. What we didn't realize when we wrote those recommendations is that if a baby is well appearing, the incidence is not near 20%. It's 20% only if the baby is clinically symptomatic. Well, many of you are aware of the sepsis calculator devised by Cameron Popolo and Gabriel Escobar. And the first paper on this was published by Cameron Popolo in 2011. Remember, it's a case control study of babies who are at least 34 weeks gestation. There are about 350 cases and 1,000 control infants in this large database. And the difference in this study is rather than using a cutoff value, for example, a temperature of 38 or rupture membranes of 18 hours, risk factors were used as continuous variables. I'll show you what I mean by that in just a second. The two best predictive values for sepsis in babies were highest maternal temperature and gestational age. So here are their data. Just to orient to these next three slides, the dotted line is the background risk of sepsis in the population. The black line is the black part of the graph is the actual data, and the red line is smoothed out data. This is again is looking at babies 34 to 42 weeks gestation. And I'm pointing out it's a U-shaped curve. Risk of sepsis goes up with immature gestations and goes up again with post-mature gestations. And this is their data on the risk of sepsis according to duration of rupture membranes. I mentioned 18 hours is significant, but you can see here with shorter durations of rupture membranes, the risk of sepsis goes up above baseline, shown in the dotted line over here, and goes up and up with increasing duration. And these are the data, risk of sepsis according to highest maternal temperature. We mentioned that 100.4 is significant, but the higher the maternal temperature, the greater the risk of sepsis in the newborn baby. So the sepsis calculator, as you know, takes these 6 variables to get a predicted probability of sepsis. Gestational age, really broken down to weeks and days, highest maternal temperature, duration of rupture membranes, is the mother GBS positive, negative, or uncertain? Did she receive intrapartum treatment, which was GBS specific or broad spectrum, and was treatment given at least 4 hours prior to delivery? And when you take our case, baby Kim, and throw in all the numbers, the predicted probability of sepsis per 1,000 live births is 1.61. Now you say to yourself, well, the background risk is about zero point 0.5. This is markedly elevated. I may want to get a blood culture and start and consider starting antibiotics in that baby. And then Dr. Escobar and Dr. Popolo went on and said, okay, we know about the risk based on historical risk factors. Let's add in the baby's clinical presentation. So we have a pretest probability, the risk of sepsis based on historical data. We have the clinical presentation of the baby, and then we have a new risk of infection based on those two variables. And by the way, that's what people call Bayesian analysis to determine posterior probability. And as you can see here, from our case that we just looked at, if you use a sepsis calculator and the baby's actually well, which baby Kim became, the risk of sepsis is not 1.61, it's actually 0.66. It's a baby you do nothing for. If the baby had an equivocal presentation, they define that fairly specifically in that article by Gabriel Escobar, the risk of sepsis jumps up to almost 8 per thousand live births. And if the baby is really ill with clinical illness, the risk is quite high. In both the latter two categories, you'd probably want to start antibiotics and take a culture. So let me now address management controversies. First, does early onset sepsis occur in infants with risk factors who appear completely well at birth? The answer is yes, and I'll show you data in just a second. Will the use of the sepsis calculator miss a high proportion of babies with proven sepsis? The answer is also yes. I'll show you the data. And how effective are serial observations alone without the sepsis calculator? In a symptomatic baby, we almost always treat. When sepsis is suspected because of clinical signs, poor perfusion, respiratory distress, cardiovascular instability, we generally give broad spectrum antibiotics. But remember, infants undergo a transition in which their clinical signs may disappear by 4 to 6 hours of life. Those infants can be observed if the clinical signs are going away, especially when there's no risk factors for sepsis, and those babies can be treated as healthy babies. So, what's the risk of sepsis in a well appearing baby? It's low. In well appearing term and late preterm babies at birth, the risk of sepsis is reduced by 60 to 70%. But it's not zero because some babies can develop symptoms as they increase in postnatal age. This is an important paper published by Wortham in Pediatrics in 2016. It's a retrospective observational study of 232 both symptomatic and asymptomatic infants, all of whom had positive blood cultures, born to women that had the diagnosis of chorioamnionitis. In fact, about half of the mothers had clinical and histologic chorio, so it was really definite. The others had either clinical or histologic chorioamnionitis alone. So what did it show? It showed that almost every preterm baby with sepsis was symptomatic. That's reassuring because you're going to treat that population. But only 3/4 of term infants were symptomatic at birth. 5 infants developed symptoms within 72 hours of birth. So they were well appearing, then developed symptoms. And this is important for me that all infants who died were symptomatic within 6 hours of birth. That tells you that your initial evaluation of the baby is critically important. If a baby is well appearing, even if they develop symptoms later on, they are unlikely to have increased mortality. And this is a calculation the authors did. The authors estimated that using current guidelines, those are the old Committee of Fetus and Newborn and CDC guidelines, that 60 up to 1,400 asymptomatic newborns born to women with chorioamnionitis would be evaluated and treated to identify one infected newborn with sepsis. That's a tremendous amount of wasted sepsis workups. And the question for us to think about is how can we improve the precision? I'm going to present to you the latest recommendations by the Committee of Fetus and Newborn. That these recommendations have been published in Pediatrics. And they start their paper with a statement which is very true. No method can be used to identify all infants with early onset sepsis with precision. Each strategy, I'm going to show you 3 strategies, has merits and limitations. Each strategy must include measures to monitor the infant and minimize the duration of antibiotic therapy. and monitor the infant, you'll see that SEER observations have more frequent monitoring than does the sepsis calculator. And birth centers have to choose a strategy that is best suited to their local resources. This is the recommendation that I hate because it's the same old fashioned recommendation from the CDC. I'm putting it on to be thorough, but I don't support this recommendation because it uses risk factor threshold values to identify infants at increased risk for sepsis. And you can see there's three ways you can use this information: lab testing and empirical antibiotics, shown by a single asterisk, lab testing alone, shown by double asterisk or observation. And they said any newborn infant who's ill appearing or born to mother with clinical chorioamnionitis needs lab testing and empirical antibiotics. I think that's an old fashioned recommendation. I would not adhere to it. If the mother is colonized with GBS who received inadequate treatment with a duration of rupture membranes greater than 18 hours or a gestation less than 37 weeks, they recommend laboratory testing. I think laboratory testing in itself has poor positive predictive value. And the last, they said maternal colonization with GBS who receive inadequate prophylaxis, but no other risk factors. You can observe those babies. Maybe I agree with that, but the first two recommendations I do not. So they called this categorical risk assessment, and there's been lots of limitations raised about it. No clear definition for what is clinically symptomatic, difficulties in establishing a diagnosis of maternal intraamniotic infection, inconsistent consideration of intrapartum antibiotics, and no clear guidelines for an abnormal test. And that brings us to what they call multivariate risk assessment, and we all know it as a sepsis calculator. And it's based on an extremely large cohort of over 600,000 newborn babies, uses objective data at birth and the evolving newborn condition at 6 to 12 hours of life. And they recommend for a baby who has a risk greater than 1 per thousand but less than 3 per thousand, blood culture and enhanced clinical observations are recommended. They mean every 4 hours, and that may be a problem. That may not be frequent enough. And any baby with a risk of sepsis greater than 3 per thousand, they recommend antibiotics. This is a fairly recent meta-analysis looking at how the use of the sepsis calculator has affected use of empirical antibiotics. It's highly significant. Here is the risk ratio, and there are the confidence intervals down there. And the largest study is by Kuznowitz, published in JAMA Pediatrics in 2017. They looked at the monthly sepsis evaluation rates before the sepsis calculator was introduced into the Kaiser Permanente system during a learning period in which they used the basic calculator, but not one that included clinical signs. And here's the full sepsis calculator, again showing a marked decrease in sepsis evaluation rates. Limitations of a sepsis calculator: it misses a substantial proportion of infants with early sepsis, maybe as high as 40%, and recommends treatment of over 200 babies for each case of confirmed sepsis. The sepsis calculator will fail to identify some infants born to women with proven chorioamnionitis, and the definition for an equivocal presentation is likely to overlap with that of a well-appearing baby, depending on when assessments are made. And these are four retrospective applications of a sepsis calculator in four different NICUs. Here's the number of infants in the study. Here are the gestational ages. Third column is number of true positive blood cultures and the number of missed true positives. Here, every true positive was missed. In this last study by Goel, 2 out of 5 were missed. But in every study, to the speaking on behalf of the sepsis calculator, antibiotic use was significantly reduced. The limitation of the sepsis calculator. Now, I want you to be careful in the baseline risk of sepsis that you apply for the sepsis calculator. I said a general baseline risk is about a half per thousand live births, but if a mother has chorioamnionitis, the actual number should be closer to 4 per thousand live births. This recently published paper is a retrospective study of about 800 babies whose mother had clinical chorioamnionitis, and 35% of them met the criteria for a confirmed intraamniotic infection. Using a baseline risk of a half, which is just done routinely, the sepsis calculator recommended withholding antibiotics and not obtaining a blood culture in close to 70% of women with confirmed intraamniotic infection or confirmed triple I. In contrast, when using a baseline risk of 4 per thousand, which is the true baseline risk, about 60% of infants born to women with confirmed triple I would have received a blood culture and empiric antibiotics. So the point is, you have to be very careful what baseline risk of sepsis you put into the sepsis calculator. And the calculator does allow you to put in incidences depending on what population you're looking at. And then there's sero observations. Sero observations rely on clinical signs of illness. Using this approach, regardless of any risk factors for sepsis, infants who appear well at birth, appear ill at birth, and those who develop signs of illness up to 48 hours are either treated or evaluated by laboratory testing. Limitation, there's not as many studies looking at this process of sero observation. This approach requires hospitals to develop systems for sero observation and document findings. It's actually quite complex. Where do you admit the babies? Who does the assessments? How do you document it? And clearly all of that adds costs to well newborn care. And the question we all have, are frequent observations as good as using the sepsis calculator? And the answer is yes. This is a recent paper published in the Journal of Pediatrics in 2020, in which, and it's from Stanford in California, in which they use this sero observation approach to identify babies with sepsis. And the approach, all postpartum, all postpartum nurses were educated about signs of sepsis, the importance of repeated clinical assessments. A hospitalist, usually a pediatrician, attended all deliveries and assessed every baby at the time of birth. Then a level 2 nursery nurse made assessments every 30 minutes for the first 2 hours of life, then every 4 hours for the first 24 hours, and then every 8 hours. Well-appearing high-risk infants greater than 35 weeks gestation were admitted directly to the postpartum unit and roomed in with the mother. And here are their data. And we're looking at the number of babies who received ampicillin in the upper graph, and the lower graph shows percentage of babies who had a C-reactive protein measured. And you see different phases, phase 1, phase 2, phase 3. The largest or sustainability phase is phase 3, where they evaluated about 10,000 babies. And it shows that the sero observation approach reduced use of ampicillin and decreased testing for CRP. And these are 5 studies which have used the sero observation approach. And I put them on to give you an idea about how risky the sero observation approach is. So it's a risky approach if any baby experienced mortality or any baby became critically ill. So in only one study by Berardi out of Italy, in which there were 4 babies with culture-proven sepsis, 3 with severe symptoms. So I say that 3 of those babies could have been harmed, although none of the babies died. And you take all those studies together, out of more than 6,000 babies, severe symptoms developed in only 3 babies and might have been harmed by the watchful waiting approach. And therefore, I calculated a number needed to harm of over 2,000. On the other hand, the risk of IV infiltrate is quite high, is 9.1 when a risk factor-based strategy is employed. And clearly, if you think about number needed to harm and you're treating babies with sepsis, it delays breastfeeding, and the number needed to harm is 2.1. I'm not equating IV infiltrate with severe symptoms. It just points out there are more common problems with admitting and treating every baby born to mother with chorioamnionitis. So my conclusions: babies with clinical signs of sepsis should receive empirical therapy. That's pretty obvious. Asymptomatic late preterm and term babies with risk factors of sepsis, including intraamniotic infection, can be closely observed without empiric therapy or evaluated by use of the sepsis calculator plus an enhanced observations. There are groups of preterm babies at very low risk of infection. We've already mentioned them, babies delivered from maternal indications who can be managed without antibiotics. And the last is a question: can select group of symptomatic ELBW babies be managed without receiving antibiotics? And in fact, we have an NIH grant and are doing a prospective study, at which we're randomizing ELBW babies in certain categories to receive antibiotics or to receive placebo. Well, in our case, the blood culture was negative, and because of an unremarkable laboratory value, the baby was only treated for 48 hours. I have to say the standard in our nursery for treatment is now 36 hours with negative cultures. As baby Kim grew up, he decided to style and color his hair differently and eventually became president of the United States, defeating a well-known celebrity. And here's baby Kim, you may recognize, but he's got the Donald Trump haircut and hair color. And to show you that the hair really makes the man, here's our current president with the baby Kim haircut. Obviously, you would never vote for him, which I hope we don't do in our most upcoming election, and always vote for someone like this. So I want to thank Nestor for inviting me, and hopefully I'll come and see you all in person in the future. Thank you very much.
Bueno, muchas gracias por esta excelente conferencia. Me imagino que va a generar bastantes preguntas en el auditorio y algunas controversias. Quería recordarles, por favor, que pongan la dirección de mail en el Facebook para poder contestar las preguntas que no podemos hacer en vivo. Nos van a acompañar en esta tarde como paneles reactivos de esta conferencia la doctora Liliana Vázquez, que es infectóloga perinatal, con la cual hemos compartido varios años de trabajo en Palermo, el doctor Manuel Poggi, que es infectólogo pediatra perinatal también, con la cual también he compartido varios años de trabajo en San Isidro, y la doctora Ana Pedraza, que es la jefa de la unidad de servicio de neonatología de la maternidad suiza argentina. Así que bueno. También, perdón, nos acompaña la doctora Laura Konikov, que va a ser la médica que va a hacer la traducción simultánea. Les pido, por favor, que la traducción es muy difícil de hacer y que las preguntas sean lo más pausadas posibles, que tengan un intervalo entre palabra y palabra para poder dar tiempo a la traducción y que el doctor Richard POLIN las pueda contestar. Bueno, vamos a empezar entonces la ronda de preguntas y respuestas. Si quiere la doctora Vázquez empezar, Liliana.
Buenas tardes a todos. Gracias, doctor POLIN, por su conferencia. Como infectóloga, siempre es un desafío trabajar en el uso restrictivo y adecuado de antibióticos en la unidad neonatal. Este es un punto muy importante. Los recién nacidos de término o casi de término, que nacen asintomáticos y tienen una carga de antecedentes muy importantes que muchas veces obligan a tratar niños de aspecto sano.
Hacer una pausa, Lili, porque si no, no va a poder traducir. Gracias.
Thank you so much, Dr. Polin, for your wonderful lecture. I have a question for you regarding well-looking or fully asymptomatic babies that appear well, and in the situations when they have a lot of maternal history behind them that will go for infection, and how difficult it is to provide a good stewardship regarding the use and abuse of antibiotics. Doctora Vázquez, no sé si sigue la pregunta.
Sí, no, era un comentario hasta ahora. Nosotros, al igual que las recomendaciones, hemos pasado por distintas etapas en la indicación de antibióticos a este grupo específico de pacientes. Desde hace un par de años el seguimiento que hacemos es clínico, puramente clínico.
So in the last few years, we went through different kind of recommendations following this particular population of babies, and it seems like nowadays we are more inclined to just follow up clinically the status of the babies.
Los trabajos de Wortham en el 2016 o los de Velardi son los que se adaptaron más a nuestras posibilidades terapéuticas. Así que mi pregunta es, creo que tenemos que mejorar el seguimiento clínico de estos recién nacidos internados junto con su madre. ¿Cuáles son las recomendaciones que usted nos da para hacer un adecuado seguimiento clínico?
So from our point of view, we believe that we should be following up with these babies clinically while they are in the maternity ward with their mothers. Do you have any particular recommendation for us on how to best to do this?
Yeah, I would follow the frequency of observations used at Stanford, shown in my last couple of slides, and would measure the heart rate, respiratory rate, and pulse oximetry.
Dice el doctor Polin que recomienda que usemos las guías de Stanford, mediante las cuales se establece que hay que hacer controles más frecuentes de los signos vitales básicos, frecuencia respiratoria, frecuencia cardíaca. Sorry, doctor, you said respiratory rate, heart rate, and pulse oximetry, y saturatometría.
Pulse oximetry. I would also find out how's the baby feeding, is the baby irritable, looking for other more subtle signs of sepsis.
Y buscar síntomas más sutiles como actitud para la lactancia, irritabilidad.
Quizás tenemos que mejorar la indicación de esos pacientes. Esos pacientes hoy se internan junto con sus madres, pero quizás tenemos que mejorar más la indicación en esas siguientes 48 horas, en lo que son, dentro de las indicaciones, la frecuencia de controles clínicos, digamos, bien regulares. Creo que en eso tenemos que mejorar.
Dr. Vasquez says that we probably need to work on our particular care plan for those babies, in the sense of increasing the frequency of our vital signs and follow-up in the maternity ward.
Yeah, and then you have to document the vital signs and document what the nurse is observing for medical legal purposes.
El doctor Polin dice que desde el punto de vista médico legal es muy importante que quede documentado en la historia clínica los controles de signos vitales y otros aspectos del bebé.
Muchas gracias.
Thank you, doctor.
Manuel, ¿querés hacer alguna pregunta? Emma.
Manuel, tenés que
el
liberar
micrófono.
el micrófono.
Ahí estás.
Bueno, buenas tardes a todos. Agradecerle al doctor Polin la excelente exposición, que ha sido muy completa y muy clara. Nos ha quedado claro que actualmente el manejo de los neonatos asintomáticos, pero que tienen riesgo de sepsis precoz, el manejo continúa siendo controvertido, y los distintos enfoques, estrategias propuestas, como dijo el doctor, tienen sus ventajas y sus limitaciones. Yo quería hacerle una pregunta en relación a este grupo de recién nacidos que él mencionó, con taquipnea transitoria, que son recién nacidos de término o pretérmino tardío, considerando que la taquipnea transitoria, los signos clínicos son inespecíficos y pueden obedecer a patología respiratoria grave muchas veces. En la práctica diaria es muy frecuente que usemos el tratamiento antibiótico empírico presumiendo neumonía en estos recién nacidos, pese a que esta recomendación no está basada en la evidencia, pero es un escenario en donde usamos mucho el tratamiento antibiótico. Él mencionó que podríamos
para un segundito, Emanuel, para que le pueda traducir, por favor.
Sí, cómo no.
So thank you so much, Doctor, for your lecture. It was a very thorough and very concise and clear lecture on the topic. It's quite a controversial topic to talk about treatment in asymptomatic babies. My personal focus of interest today is, what do we do with those babies that come in the NICU with respiratory distress, TTN type of clinical picture that could mask potential pneumonia, and with those particular symptoms? Sí, adelante, Manuel, te lo resumí.
Sí, muy bien, gracias. Bueno, en realidad en este grupo de pacientes que no tiene factores de riesgo para sepsis precoz, si él nos puede recomendar, como también le preguntaba recién Liliana, un mejor seguimiento a la hora de tomar la decisión en el inicio del tratamiento antibiótico.
My question for you would be, what should we do with these babies that come in the NICU with a TTN presenting with this particular spectrum of symptoms? What should we do in terms of antibiotics? Because it seems like more so than often we tend to prescribe antibiotics even though the risk factors might not be there.
It's a great question. I didn't cover it in my lecture, but it's a common problem. I don't know if you want to translate that.
Yeah, sure. El doctor dice que es una muy buena pregunta, que no lo trató en su charla, pero que es algo que sucede en las neos con mucha frecuencia.
And if there are not major risk factors for sepsis, like intraamniotic infection, in a baby who has clinical signs of TTN, I would not treat that baby. We would just observe that baby and provide CPAP or normal ICU care, but not antibiotics.
El doctor dice que si es un bebé que no tiene factores de riesgo para infección intrauterina o antecedentes maternos de relevancia, son pacientes que no los trata con antibióticos empíricos, simplemente sostén clínico, CPAP, lo que usemos en nuestras unidades.
Muchas gracias.
Thank you, doctor.
Anita, ¿querés hacer alguna pregunta?
Y es en realidad, perdón, sí, estoy bien. Es un complemento de la pregunta que hizo Emanuel. Y el mismo grupo de pacientes, chicos prematuros tardíos, términos tempranos, que son muy frecuentes, no son una aguja en el pajar en nuestras unidades. Decime, Laura, cuando querés que interrumpa. Y que necesitan más que observar, digamos, que precisan algún apoyo respiratorio. Ventilación, oxígeno, ventilación invasiva, no invasiva, y que llegan a las 6 horas de observación, continúan, a veces con pocos requerimientos de oxígeno, pero por el solo hecho de continuar se medican, se tratan y se medican.
Ahí le interrumpo, Doc, así le traduzco hasta acá. So my question for you, doctor, is very similar to Dr. Poshi's question regarding these particular population of babies, late preterms or early term babies that need respiratory support. What do we do after 6 hours when the symptoms are still there, have improved but only mildly or not improved at all? And it seems like we are prone to start antibiotic treatment at that point. Sí, Doc, perdón.
En el ensayo aleatorizado que el doctor mostró al final, que es en prematuros chiquititos, ¿no? En menos de 28 semanas, los criterios para incluir en placebo versus tratamiento fueron asistencia ventilatoria hasta 40% de FIO o ventilación no invasiva hasta 60% de FIO, que es un número importante.
Perfecto. So in the study that you showed us in your presentation, which was, I understand, for smaller premature babies, non-invasive ventilatory support or increased oxygen requirements above 40% was the criteria. Sí, perdón, doctor.
Nada, mi pregunta entonces sería, en estos chicos que llegamos a las 6 horas y requieren 30%, 50% en una ventilación no invasiva, ¿cuál es el límite que ellos ponen en los prematuros tardíos o términos tempranos, sin antecedentes de infección, para cultivar y medicar?
So what do we do in these particular situations if after 6 hours things are not improving or only improving very mildly in late preterms or early term babies with no history of maternal infection whatsoever? What do you do?
What do? I watch and wait. The natural history of TTN is not to get better in 4 or 6 hours, but to get better over a day or 2 days, sometimes even 3 or 4. So I would not treat those babies, making sure that they're not any worse. If their FiO2 is increasing and they're getting sicker, then obviously we have a low threshold for beginning antibiotics.
Thank you. El doctor POLIN dice que no haría nada o que en realidad watch and wait, o sea que solamente haría una observación clínica, que la historia natural del distrés transitorio, de la taquimia transitoria es que mejoran alrededor de las 24 horas de vida, pero que si es un paciente que a las 6 horas se está empeorando, aumentan los requerimientos de oxígeno o algún otro síntoma clínico aparece, sería prudente iniciar tratamiento antibiótico. Pero si el bebé está igual o mejor, no.
Okay. Muy bueno. Florencia, ¿tenés alguna pregunta del público?
Justo le acaba de contestar el doctor POLIN, que tenía que ver en cuanto a cuánto tiempo uno esperaba en tratar la taquimia transitoria. Justo le respondió el doctor.
Bueno, buenísimo. Coco, ¿algún comentario?
Sí, muchísimas gracias, Richard, por la charla. Yo solo un comentario breve para la gente y luego una pregunta para el doctor Polin. El comentario breve es que a los que les interesa profundizar o probar usar el Sepsis Risk Calculator está libre en la web. Es muy simple de usar, la única exigencia es que tienen que tener una noción de la incidencia de sepsis estreptococo en el lugar donde trabajan, y si no, habría que tener una incidencia en la región donde trabajan o en el país eventualmente para poder usarlo. No estoy diciendo que lo usen, solo que a los que les interesa, porque hay gente que les gustan los scores, los puntajes, entonces esa gente puede usarlo gratis en la web. Si le quieres decir breve, Laura, yo espero.
Sí, cómo no, Doc. Dr. Vine is reminding all of our audience that the risk calculator is available online for free for anyone to take a peek and have a look. But he is also reminding us that we need to know the incidence of GBS sepsis in our particular units, our cities.
Ok, y la pregunta está relacionada con esto. A ver, es muy difícil que sepamos justo a quién hay que medicar, y por más que nos cuidemos y mediquemos menos, siempre vamos a estar medicando más chicos de los que realmente están infectados. Y eso es mejor que no medicar a uno que está infectado. Nosotros, y esto desde hace muchos años, con la doctora Liliana Vázquez en Trinidad, Palermo, y con cada uno de mis colaboradores, que son un grupo excepcional de gente que se dedica a enfermedades infecciosas neonatales en Palermo, en la actualidad ayudada por Patricia Glassman, Emanuel y Debbie Greco en San Isidro, y Fabiana García en Ramos Mejía. La verdad es que tenemos una especie de policía adentro de la unidad que se ocupa, entre ellas y la enfermera en control de infecciones, de ver que si un chico tiene cultivos negativos, se suspendan los antibióticos. Rápidamente, 24 horas, 36 horas, la mayoría de los hemocultivos son positivos en las primeras 24. Si él usa este tipo de sistema, o si tiene algún sistema, porque existe, de suspensión automática de la indicación, que las indicaciones se cancelan automáticamente si no son reescritas a las 24, 36. Perdóname, Laura, fue largo, pero creo que el concepto lo puedes
Creo que lo agarré. Dr. Vine wants to ask you a question, Doctor. He's saying that it seems like it's very easy for all of us to overtreat babies that are undertreat babies, because we don't want to risk the fact of missing one, and for that we overtreat. So he's thanking all of the members of his team, wonderful colleagues and professionals that have been working towards controlling the use of antibiotics in the units in the last few years. And they work with an ID specialist and an ID specialist nurse to work sort of like a police, antibiotics police in the unit. They let you go around and check that after 24 hours, 36 hours of negative blood cultures, antibiotic treatment is stopped. So Dr. Vine wants to ask you, do you have that particular person, antibiotic police, working with you, or do you actually have that system in which you can automatically, orders are automatically canceled if antibiotics are negative, if cultures are negative, sorry.
So we don't have antibiotic police. Maybe we should, but many units in the U.S. have automatic stop orders. So after 36 hours or 48 hours, if the clinician wants to continue antibiotics, they have to write a new order. I think automatic stop orders are a reasonable approach to limit the duration of antibiotic use.
Dice el doctor Polin que no tienen nada parecido a un policía de antibióticos, ni mucho menos, pero que sí usan este sistema de que si es necesario continuar un tratamiento antibiótico, la duración de la prescripción dura solo 24 horas y hay que tomarse el trabajo de volver a escribirlo, y le parece que eso es una manera de controlarlo.
Muy bien, tengo una pregunta del público que dice que en los pacientes que deciden ponerlos en observación, ¿qué adherencia del staff de médicos de la unidad tienen para no medicarlos?
Here's a question from our audience, doctor. In terms of babies that are only clinically monitored, what's your staff at your hospital, at the NICU? Do you find that it's easier for staff to follow those orders? What's the degree of compliance to the orders of just watch and wait for those babies that are clinically well? I don't know if you understand the question.
Yeah, they're not rules, but they're guidelines. And guidelines allow for individuals to look at the baby and change their approach depending on how they think the baby looks. I mean, experienced clinicians recognize the signs of sepsis. Inexperienced clinicians may not, but every clinician can modify the guidelines as they see fit.
Dice el doctor Polin que en su unidad no hay reglas, sino guías, que cada médico ejerce su propio criterio individual, que es cierto que los médicos con más experiencia pueden pesquisar síntomas más sutiles que los médicos con menos experiencia, pero que cada uno ejerce su criterio individual para decidir qué es lo mejor para el paciente.
Muchas gracias. ¿Alguna pregunta más del Zoom? ¿Alguno que quiera hacer alguna pregunta? Yo le quería preguntar al doctor Polin, acá en la Argentina hemos tenido situaciones legales con chicos no medicados, con pacientes bebés no medicados, y quería saber cuál es la situación legal en los Estados Unidos con respecto a no medicar pacientes que después pueden ser sintomáticos.
Dr. De Caro has a question for you. It's a legal medicine, legal practice question. He's commenting that in our country, we have cases in which parents present 5 lawsuits because babies were not treated when they were supposed to be treated. And he's wondering if you have that issue in the States or in your unit.
The answer is yes. We have families that will initiate litigation based on a bad outcome. But I think in most instances, it's easy to defend the doctor's practices for not starting antibiotics, as long as they approach it in a rational fashion.
The family, you mean, the rational fashion?
Well, the family has a right to sue if they think the outcomes are not as good as they had hoped. On the other hand, I think most of those lawsuits are very defensible, and families do not win them with the proper experts defending them.
Dice el doctor que sí, que hay de estos casos y muchos, pero que en la gran mayoría de los casos es sencillo defender al médico que no indicó tratamiento antibiótico, por supuesto si había una base científica convincente de que hizo lo que tenía que hacer.
¿Alguna pregunta más?
Podrían, si quieren preguntar nuevamente los del panel, vi que está Marcela Ortiz de Zárate y otras infectólogas que si tienen ganas de hacer alguna pregunta van a ser bienvenidos cualquiera de ustedes, y si no lo dejamos libre al doctor Polin.
Yo quiero hacer un comentario, perdón Ana,
No,
que hemos discutido muchas cosas, pero no hemos puesto el laboratorio como una variable en medicar o no medicar. Entonces, ni hemograma ni reactantes de fase aguda para poner los antibióticos ni para sacarlos. Estamos hablando de score que evalúe el riesgo de sepsis, y estamos hablando de qué pasa con cuál es la predicción de sepsis en un paciente con síntomas clínicos. Creo que este es un dato muy importante para sepsis precoz. Y el segundo dato es que hay trabajos muy importantes como el de Bortham, que citó el doctor Oberardi, que es una experiencia que también mostró el doctor con casi 4.000 pacientes seguidos en sepsis precoz, seguida por síntomas clínicos, que ninguno de los pacientes que estando asintomático se volvió sintomático después, se murió por ponerle tratamiento antibiótico cuando cambió clínicamente.
Le traduzco la primera parte,
Sí,
primero puede ser, porque
sí,
es una pregunta un poco compleja. So,
Dale.
doctor, I have a question for you. Dr. Vázquez has a question for you. You lecture extensively about clinical symptoms and the SCORE risk calculator. What do we do about blood work? We have not mentioned anything about CRP, WBC. What are your thoughts on using those parameters to either start or to stop the antibiotic treatment in a baby?
So I do not think that laboratory testing, acute phase reactants, or white blood counts or differential counts are useful at all for identifying babies who are infected. Therefore, I do not use them to start antibiotics. On the other hand, if I want reassurance that if I'm not starting antibiotics or I would like to discontinue antibiotics, then those laboratory tests have a very high negative predictive value and can offer you reassurance the baby is not infected.
El doctor Polin dice que en la práctica para iniciar tratamiento antibiótico no los usa porque estos son laboratorios que muchas veces no están alterados al inicio y que además los reactantes de fase aguda y el recuento diferencial de glóbulos blancos tienen un alto valor predictivo negativo, con lo cual la utilidad es limitada. Perdón, doctora Vázquez, ahora sí, ¿me puede repetir la segunda pregunta que era más compleja? Sí, Dr. Vázquez has another question, so I'll translate for you now. ¿Me la puede repetir?
No,
la segunda
era
parte de la
solo un comentario hacia los pacientes con sepsis precoz que nacen asintomáticos y evolucionan en las siguientes horas con síntomas. De esos pacientes que recibieron tratamiento no al nacer, sino cuando tuvieron cambios clínicos, ninguno de ellos falleció por sepsis. Entonces, que creo que la observación y el seguimiento es realmente un buen parámetro para definir solo la observación clínica, quién merece tener evaluación y tratamiento y quién no, y que ese grupo de pacientes, me parece que lo que tenemos que mejorar es el seguimiento junto a la madre, o sea, estandarizar y normatizar como una indicación médica, como si le indicáramos antibióticos, con qué frecuencia ese paciente tiene que tener controles clínicos, que me parece que en eso tenemos que mejorar.
Dr. Vázquez, it's not really a question, it's more of a reflection. Exactly. So the piece of literature that you showed, she was thinking about the fact that most babies that were not started antibiotics at birth, but after 6 hours they were, because their clinical condition worsened. None of those babies passed away or had any other major complications. So she is thinking that this is what we need to do here. We need to improve our clinical practices in order to monitor these babies in a better fashion. Because for what you told us, it's okay if we delayed antibiotic treatment for a couple of hours. We just need to make sure that we get there on time.
I would agree with that.
Sí, está de acuerdo, doctor.
La doctora Marcela Ortiz de Sara te quiere hacer una pregunta.
Sí, buenas tardes. En realidad un placer la charla que venimos escuchando hasta el momento. Pocas preguntas me quedan al respecto, pero sí me interesaría saber el rol o la jerarquización que se está dando, si nos puede comentar algo el doctor con respecto a la jerarquización que se hace con el tema de las 4 horas o menor tiempo de colocación de la profilaxis, viendo ahora que algunos trabajos ya empiezan a plantear 2 horas como una alternativa adecuada, de considerar adecuada la profilaxis intraparto.
So thank you so much for your lecture, Doctor. It was such a joy to listen to it. I have a question for you regarding the maternal prophylaxis, the antibiotic prophylaxis. I've been reading some publications that state that even up to 2 hours before delivery could still be effective. Do you agree? Do you have any comments?
That's what the literature says now, that even 2 hours prior to delivery for a mother who's colonized with GBS is an effective strategy. So I think the CDC guidelines that look for 4 hours are outdated, and 2 hours is probably sufficient.
Es el doctor Polin que sí, que por la evidencia que conocemos hasta ahora, aparentemente hasta 2 horas antes del nacimiento del bebé tiene eficacia y que es posible que cambien las guías del CDC basado en esto también.
Muy interesante. Ana, vos querías hacer un comentario que te frené.
No, no sé si hay tiempo, es una cosa simple. A ver, los hemocultivos tienen a veces baja sensibilidad, sobre todo si uno no toma la cantidad adecuada de muestra. Los neonatólogos somos bastante tacaños en cuanto a extraer muestras y habitualmente tomamos 2 hemocultivos con menos cantidad de sangre. Liliana Vázquez en esto ha tenido mucho que ver y ella prefiere, y nosotros estamos haciendo eso en este momento, aunque no hay muchos datos en neonatos, un hemocultivo, pero que tenga 1 mililitro, no 2 de 0,5, porque eso mejora la sensibilidad. No sé cuál es la opinión del doctor. Liliana, es tuya la pregunta, ¿eh?
Dr. Pedraza has a question that comes from her and Dr. Vázquez, actually, regarding the blood sample for blood cultures. Seems she's reflecting on the fact that neonatologists would seem to be pretty cheap with blood, baby's blood, and we tend to send 2 samples with 0.5 milliliters or even less, but lately we seen that it's more effective or we increase our sensitivity by sending just 1 culture, 1 milliliter of blood. Is that what you do in your unit? What's your current practice?
That is our practice. We try whenever possible to draw 1 ml. It's sometimes very difficult in a very tiny premature baby, but our preference is to draw 1 ml for culture.
Sí, el doctor dice que hacen eso también, que incluso en los bebés muy chiquititos les cuesta, pero que mandan 1 mililitro. Un cultivo, 1 mililitro.
Coco, ¿vos querés hacer algún comentario?
No, yo creo que el doctor Polin debe tener que tomar el té a esta hora, así que habría que autorizarlo. ¿Querés traducirle, Laura?
So, doctor, we fear that we're keeping you away from your tea.
Y por otro lado, quiero agradecerle muchísimo a él por su conferencia y a Laura, esto no hace falta que lo traduzcas, la verdad que estoy impactadísimo con tu calidad de la traducción.
Sí,
Estaba prevista, te habían hecho demasiada publicidad, creo que perdiste, Laura.
Eso es culpa de mi jefe, el doctor Mariani, es culpa de él.
Decile a tu jefe que te vamos a robar para todas las conferencias.
¿Sabes lo que pasa, Doc? Que como mi marido es inglés, yo practico todos los días.
Está bien. Bueno, así que les agradecemos mucho a todos los que estuvieron presentes. Marcelo, vos cerrá para indicar cómo seguimos. And thank you very much, Richard. It was a pleasure to have you. We'll let you rest, and now we'll have a break and have another conference, but I don't think that you will take advantage of it because it's in Spanish. Even if you are in New York and you have to speak Spanish frequently with patients, I doubt that you will be interested in this lecture. So we'll give you a break now to you, and Marcelo will close for announcing the next talk.
Bueno, muchas gracias. Vamos a hacer una breve pausa de 5 minutos como en las conferencias anteriores y después retomamos con la conferencia de la doctora Mariana Seriotto. Muchas gracias a todos y reitero, me pareció excelente la traducción de Laura, en serio, buenísima.
Thank you, doctor. It was an honor.
Thank you for inviting me. Please, everybody, stay well.
Thank you.
Thank you, you too.
Nos vemos en 5 minutos. Muchas gracias.